Hello, my name is Efstathios Kastritis, and I'm a physician working in the Department of Clinical Therapeutics at the National Kapodistrian University of Athens in Greece. On behalf of my colleagues, I will present some data regarding the real-world efficacy and toxicity of Selinexor, and also we will evaluate the importance of dose intensity and post-progression outcomes. So this is the background of the study. As you know, Selinexor is the first-in-class exportin inhibitor. It's a drug that is given orally, and it has been approved for heavily pretreated patients who are pentaclass refractory in combination with dexamethasone, and has also been approved for relapsed refractory myeloma in patients with 1 to 3 prior lines of therapy in combination with bortezomib and dexamethasone. So in clinical practice, we use either the Selinexor dexamethasone or Selinexor bortezomib combination. However, the use of Selinexor has also been associated with GI toxicity, appetite loss, hyponatremia, fatigue, which quite often require aggressive management. These toxicities may also limit the use of this drug, and this may be a limiting factor that could be also associated with reduced efficacy. These events were managed very aggressively in the context of the clinical trials. However, outside the context of the clinical trials and the real-world setting, this may not be so efficacious. We also think that it's very important to evaluate the outcomes after progression to Selinexor therapy, given that the treatment options for these patients are really very limited. So the aim of this study was to provide a real-world report, a real-world evidence for the efficacy and the clinical use of Selinexor combinations, as well as the outcome post-progression to Selinexor-based therapies. This was a retrospective analysis, which, however, included all consecutive patients with relapsed refractory myeloma who were treated either with Selinexor and dexamethasone or with Selinexor, bortezomib, and dexamethasone in our department, the Department of Clinical Therapeutics. We prospectively collect the data for all our patients treated with myeloma at any line of therapy and with any combination of therapy. And we also collect prospectively safety data. However, the data here were analyzed retrospectively. The management of GI toxicity, which is a major issue with Selinexor, was based on the guidance that was provided by experts in the use of Selinexor. As you see, Maria Gavretopoulou is the first author in this paper, who also works in our department and is also a co-author of this abstract. So these are the characteristics of the patients that were included in the study. These are 44 patients who were treated with Selinexor-based combinations outside the context of clinical trials. And as you can see, these were heavily pretreated patients. You can see that the median number of prior lines of therapy was 6, and the median time from diagnosis was 6 years. All patients were lenalidomide refractory. Almost 90% were pomalidomide refractory, PI refractory, carfilzomib refractory was 70%. About more than 90% were refractory also to daratumumab or cetuximab, and 1/3 of the patients had a prior treatment with anti-BCMA therapy. In this case, all patients were pre-treated with belantamab mafodotin. As you can see, the median age of our patients was 69, which is a very typical myeloma age, and the characteristics were also typical of a heavily pretreated population. Regarding the treatments that were used, the regimens were in 48% Selinexor with dexamethasone, and in 52% of the patients were Selinexor with bortezomib and dexamethasone. And as you can see, in 37% of the patients, the starting dose was below 100 milligrams per week. And in 63% of the patients, the dose was more than 100 milligrams per week. The median duration of Selinexor therapy was almost 3 months. It was 2.7 months to be accurate. On intention to treat, the overall response rate was almost 30%, 29.5%, and there were also 2 patients who achieved the complete response. As you can see, the response rate was 35% for patients treated with Selinexor, bortezomib, and dexamethasone, and 24% for patients treated with Selinexor and dexamethasone. However, in patients who had been previously exposed to ADBCMA therapy with belantamab, the overall response rate was low. It was 13%. It was just 2 out of 15 patients. The median time to first response was 1 month, and the median progression-free survival was 3 months for the whole cohort. And for the responders, it was almost 7 months, indicating that patients treated with Selinexor who achieve at least a partial response may have prolonged progression-free survival, of course, given the limited options that these patients have and their poor prognosis, given that they are heavily pretreated. So there was no significant difference in the progression-free survival for patients treated either with Selinexor and dexamethasone or with Selinexor, bortezomib, and dexamethasone. And also, there was no significant difference in the progression-free survival for patients treated with less than 100 milligrams per month versus patients treated with more than 100 milligrams per week versus patients treated with more than 100 milligrams per week. However, we have to note here that most patients treated with less than 100 milligrams per week were also treated with bortezomib. Here you can see also in the figure the progression-free survival and the progression-free survival, especially of patients who achieved at least a partial response with the green color. Now, a dose reduction for Selinexor was required for more than half of the patients, for 56% of the patients. And this dose reduction was required in 70% of the patients that started therapy at above 100 milligrams per week, versus 37.5% for patients that started therapy with less than 100 milligrams per week. However, as you can see, dose reduction was not associated with worse progression-free survival. And actually, patients who reduced the required dose reductions may have had a slightly better progression-free survival, but of course, this may be biased. Now, this is a small study with 44 patients. However, in univariate analysis, we identified that very low levels of serum albumin below 3.5 grams per deciliter was a significant prognostic factor for worse outcome, as well as increased LDH above the upper limit of normal for our institution. What is notable, however, is that the number of prior lines and prior exposure to ADBCMA therapy were not independent factors for progression-free survival. And I think that in this figure, you can appreciate the importance of albumin above 3.5 grams per deciliter for better outcome in patients treated with Selinexor-based regimens. However, we have to note here that this albumin level may also be associated with the nutritional status of the patients or the other characteristics of the disease, for example, the burden of the disease and the levels of IL-6. The median overall survival for the whole cohort was almost 14 months, and at the time of analysis, 16 patients remained alive. However, for patients who achieved at least a partial response, the median overall survival was 28 months, which I think is respectable, given that these are heavily pretreated patients. However, for patients failing to achieve a response, it was just 4 months, which of course is indicative of the poor prognosis of these patients. Again, in univariate analysis, the low levels of serum albumin and high levels of LDH were poor prognostic factors. And as you can see, these were patients who had a very poor outcome. Regarding post-progression outcomes, 20 out of 44 patients received further therapy. At that time, they had a median of 7 prior lines of therapy. This is extremely heavily pretreated population. And some patients received belantamab mafodotin. Some they received again anti-CD38 combinations, PIs with the chemotherapy, PIs with IMiDs, and other various combinations. In 2 patients, proteasome inhibitor was added to Selinexor with dexamethasone. And as you can see, the overall response rate to this further therapy was respectable. It was 40%, and the progression-free survival was 3.4 months. Of course, you know that these are not destination therapies. These could be bridge therapies that could be useful if the patients also have other treatment options. Regarding the toxicity, you can see that the most common toxicities were the known for Selinexor, such as fatigue, thrombocytopenia, nausea, hyponatremia. We also noted that a significant proportion of patients, 18%, also reported confusion or had symptoms of confusion or altered mental state. And 16% also had grade 3 or 4 infections. In conclusion, in this study, which is done outside the control of clinical trials, the efficacy of Selinexor combinations in heavily pretreated patients is moderate, is what we see also in the clinical trials. It is similar to the results reported in the clinical trials. However, responding patients may have a higher probability for longer remissions and also for a prolonged overall survival. We think that this combination of Selinexor could be a bridge to a more effective therapy, for example, for patients who may be eligible for CAR T cells or bispecific antibodies. I think that it's very important that the overall survival in this heavily pretreated population exceeds 1 year, and this sets the benchmark for the evaluation of new therapies. Although in the last ASH, we had the opportunity to see the efficacy associated with the use of CAR T cells and bispecific antibodies. Regarding the use of Selinexor, dose adjustments are required in most patients, indicating that the optimal dose of Selinexor may be lower than the recommended one, and one has to be very aggressive for the management of complications associated with Selinexor as well as dose adjustments. Finally, the prognostic impact of low serum albumin in these patients should be further evaluated, as it may be a marker of poor nutrition, advanced disease, and poor tolerance to Selinexor, and could be useful to select some patients for perhaps other therapies or patients who could probably avoid Selinexor because of toxicity. Thank you very much for your attention.